around 1.3, what they call the R naught, being above 1. That means every person who gets infected infects 1.3 other individuals. So that means from a statistical standpoint, a mathematical standpoint, it's growing still in Indiana. Now, the R naught, the transmission rate's much higher in the south right now, closer to 2, as we see the hot spots pick up in the areas I'm sure you see on the news. Indiana has had some hot spots picking up. Evansville area, Fort Wayne, Allen County, Elkhart County, Northwest region still continues to run transmission rates above 1. We need to obviously get that down to less than 1, down to 0.9, 0.8. That means then the virus is going away, but we're a long way from that. 7 months is a very short time in virology and immunology and trying to understand the entire picture of the COVID, the coronavirus. But we have learned some things, quite a few things. The fatality rate has been dropping. One, because of the reason, as we said earlier, younger people are getting it. But two, as we've learned more about it, we're getting better on our treatments that we have. We're learning new treatments. We're understanding that proning of patients, which means rolling them over, helps more than even a ventilator did. We aren't using as many ventilators as we were at first. Pressurized air was not a treatment that was as good as the lower pressure air. So we're using more BiPAPs, CPAPs for the oxygen patients that are in. We're understanding also that steroids are effective, which is odd for a respiratory virus. And we're seeing a drug called dexamethasone in high doses being effective. We're also understanding that the virus has an affinity for the ACE receptors in the body. Without getting too complicated on that, we're learning that it looks for receptors that are involved in the angiotensin converting enzyme, and those type of cells are located heavily in the lungs, in the cardiovascular system, in the kidneys, in the liver. So we are hydrating patients much more, which is an effective treatment, along with the steroids and low molecular weight heparin, because we found that clotting has been a real problem with patients, not only in the acute treatment, but in the chronic treatment. And that comes from the effect that the virus is having in the cardiovascular system. We're also hydrating the patients because we're seeing some glomerular filtration rate decrease and seeing some kidney damage being done. So it's a broad spectrum that the virus is affecting, not just the ARDS or the acute respiratory distress syndrome. It's affecting multiple organs, but we're learning that. We're learning more. The healthcare industry shares information freely across with new care pathways available to all facilities of what people learn. And we've made a big jump in that, which has dropped the infection rate. We are open for business here, keeping things going. We practice full infection control procedures here, always have. We've been used to that. We've had 12 employees test positive out of 1,300. So that's about a 3 times lower rate than you see in the public. So we've been able to have our staff protect themselves following procedures, and we're able to protect patients. And we're back doing surgeries. We're back to almost full at our physician offices and around imaging, therapies, etc. And we're going to continue to safely treat patients and remain open, as overall health care is very important. When we had to turn back some of the elective surgeries and procedures and imaging things, we saw people getting behind in some of their preventative and wellness care. But we're back to a little over 90% capacity right now. So I've been in healthcare 41 years now, never seen anything like this. I remember the AIDS epidemic, and that was scary. That was scary for the staff, scary for the public. But this has been a little different because I think it's affected things on the economic front more than the AIDS did, being COVID being an airborne respiratory inhalation pathogen obviously increases the transfer rate. We've been very pleased and very appreciative of the support we've received from the community for the staff as they've gone through this and had fear for themselves, fear for their families, fear of the unknown, anxiety. We all have that. But the staff has done an excellent job, due in large part to really community support, but understanding their role and their need to maintain health care during this time. So I've been very proud of the staff and very, very appreciative of the community support, not just from the foundation, but the entire general population on that. But we also have a lot going on. We haven't stopped both recruitment of staff and in doing things as we look this year, expanding services, recruiting physicians. We began early this year with Dr. Mahandram, a nephrologist. She'll be practicing in the Sue Ann Wortman Nephrology Center, dialysis. Dr. Mahandram went to Duke University and University of Texas for medical school, came up to IU for her fellowship, and we're very proud to have her here joining the community and joining the Sue Ann Wortman Nephrology and Dialysis Center. She'll be a tremendous addition to our nephrology and kidney services that we have. We've also recruited and brought on board in May Dr. Stephen Kim, a urologist, to expand our services in areas with treatment like lithotripsy and urology surgery. Dr. Kim, University of Illinois Medical School, and undergraduate, originally from Illinois. And he went University of Chicago for his residency training. And we're very happy to have him join along with David Pavey, our nurse practitioner in urology, to get us full-time services in the area of urology, something we had lacked in the past. We've also expanded our wound center as we've seen a need for that service as diabetes numbers continue to increase rapidly in Shelby County. Unfortunately, we do not have good numbers in the obesity area in Shelby County. I'm seeing an increase directly then in diabetes, which leads to an increase in the need for wound care, as diabetics have a problem with wounds that are not self-healing on that end. So we feel very good to be able to expand that service. Dr. Diego, who is a nephrologist and infectious disease physician, oversees that. Dr. Lisher does our foot and ankle wound care. Lisa Castor is our full-time nurse practitioner operating that area. We've also hired on, and starts in August, a new psychiatrist, Dr. Gilpin. Dr. Gilpin graduated medical school at IU. She's finishing as the chief resident in psychiatry at Rush Memorial in Chicago. It's the #1 resident coming out of the program, originally from the Indianapolis area. And she's coming to help us expand our behavioral health services. That's one area that continues to expand: anxiety, depression, psychological issues, drug addiction continues to grow at an exponential rate. And Dr. Gilpin will join us in August to help expand those services along with our psychologist. We have 5 psychologists who practice along with our primary care physicians, of course, to provide our behavioral health services. We've also recruited, who starts in August, Dr. Gemma, an IU medical school grad, originally from the Indianapolis area, currently at Johns Hopkins doing his fellowship, an expanded fellowship in endocrine surgery, which will expand our abilities to work in hormonal surgery issues such as thyroid cancer, etc. We're very happy to have Dr. Gemma joining us this summer. So this year, we've added on then significant number of physicians we're very happy with to go along with the number of physicians that we added last year that brought on. Of course, we brought Dr. Show, Dr. Sano, 2 physicians. Dr. Show completed his residency at Geisinger, Pennsylvania. Dr. Sano, IU, both for medical school and residency. Dr. Show, general surgeon. Dr. Sano, anesthesiologist. Both were raised here in Shelbyville as Ryobi employed their parents in executive positions. So they were raised here and came back here to work, along with another individual who came back, Dr. Melanie Stevens, in family practice, Melanie Clark. I'm sure many of you know her. She was IU also for medical school and her residency. And we look at that with 3 doctors coming back to the community. Very good to see from a standpoint of people wanting to come back to Shelbyville, practice here, and give back to the community that they were raised in. We also brought on board last year Dr. Joel Jager in musculoskeletal sports medicine. He did his fellowship at Notre Dame. Excuse me, sorry. His fellowship at Notre Dame, came back here and helps expand both our sports medicine program, but also our non-surgical musculoskeletal program. Foundations played an important role as we look at these 8 physicians we brought to the community in the last 24 months. The facilities play a big role, the technology plays a big role, but the people play a big role. All of our care is really based on the ability of staff. Physicians, of course, as our clinical leaders, but nurses, pharmacists, lab tech, imaging techs, all of the staff, that's what makes up the institution more than just the technology or more than the facilities. And we've been very proud to be able to recruit the quality of physicians we've seen over the last 10 years, along with the improvement in facilities that we've been able to put forth from a strategic standpoint and looking long term. You look at these 8 physicians, for an entire generation, they'll be able to improve the quality of care here in Shelby County, and such an important component overall healthcare and the quality of life and the economic development of the county. And the foundation has played a key role in that. And let me mention a little bit about, before I turn over for questions, if you've been on North 9, you may have seen progress coming along on the MHP Community Health and Wellness Center. We're full in construction, have been doing that since February. Most of the steel is up now, completed. You're seeing work being done for a projected timeline of second quarter of next year to be completed. It will house Dr. Howard's lifestyle medicine and bone clinic program. We will have nutritional education programs in there. Senior services will occupy with their programs, part of the center. And of course, we're bringing into the community the YMCA with a nice warm water pool and their program that they have for all ages. The 66,000 square foot building continues to proceed. We've not been slowed too much by the COVID on that. Most materials have been coming in, so we feel good about that. It'll be very important for us to get the skin on the building before winter sets in. I get the question sometimes of why are we involved in this type of project. This goes to the core of our mission and to the core of our long-term strategic planning. We want to see, and Major's being very bold in this area, we want to see a conversion really from MHP being only a sick care facility to focusing on being a health care, meaning focusing on not only taking care of people when they're acutely ill, but playing a significant role in preventative care, wellness care, in being reimbursed in a methodology that incentivizes the health system for outcomes of quality of care. For example, how well do you prevent people from going from pre-diabetes to diabetes? How good a job do you do in keeping asthma patients or congestive heart failure patients from being admitted to the hospital, being able to treat them in the outpatient world? And working with our insurance companies and working with our employers locally to develop payment methodologies that focus more around that, what we call population health management. That facility is going to play a key role in our outreach into the community in the population health management world and in preventative care and wellness care. So we look forward to that. We also believe the center will help from a quality of life standpoint in the community as an economic stimulus tool here on the north side by bringing some services, both in partnership with senior services and in partnership with the Y, that currently aren't available, as we look to improve the overall quality of life for the community. You know, I'll finish as I look back over the last 10 years or so. None of this would be possible without the foundation support. The new medical center we have, the Sue Ann Wortman Nephrology and Dialysis Center that we have, the Community Health and Wellness Center. Without the support of people like you in the community, and not just financial support, but human support, very important in what we have. We would not be able to recruit these physicians we've brought to the community. We would not be able to recruit the staff we see that we have. We would not be able to produce the quality metrics that we have. We're not perfect. We make mistakes. We are human. But really, with the support we've seen from the community and from the foundation, we've been able to bring people in who have created a culture for a commitment to excellence, for a commitment to continuous improvement. And we're constantly striving to do that. And you can be very proud of the overall health care we provide for the community. And that is due in large part to you. With that, I'll quit preaching on what we have and take some time to take questions, whether it's on COVID, whether it's on some of our new physicians or the wellness center or any other topic that we have.
Jack, I've had a question come in over the chat. Can you tell us a little more about the hospital's goals over the next 3 to 5 years?
I touched a bit on our goal in the next 3 to 5 years, and that it's going to focus on around a continued movement from fee for service to a value-based purchasing reimbursement methodology. That means getting paid for quality, not just for volume of services provided. So most of our goals and most of our strategies revolve around improving those metrics of population health, percentage of diabetes, percentage of congestive heart failure. How well do we do on process metrics within treating those? We've been very happy so far with what we call the VBP metrics. Excuse me. But that's where the majority of our strategies over the next 3 to 5 years fall. And those have been built from the facilities that we put together.
How'd the new facility do for us when we were like at the height of the most recent COVID business?
Well, I think the most important thing that they did from a standpoint was really the infection control capabilities the new facilities brought. From the expansion of isolation rooms, the separation where our inpatients who had COVID are completely isolated from any other patients second floor isolation from other areas of those seeing physicians, and of course, first floor separation for ancillary services. So it really allows maximum infection control procedures and safety from that standpoint. I'd say that was the biggest thing during COVID that it did.
Would we have been able to do that as well downtown?
No, we did not have the HVAC system capabilities of completely utilizing outside air. So there's no recirculated air in these critical areas. It's fresh air in and that air goes out. The old building, it was a self-contained system of ventilation. I get some questions a lot of times about vaccines. Where are we on the vaccines? You're seeing several vaccines moving to the large-scale testing phase, which means a minimum of 30 to 50,000 test subjects starting to get injections of vaccines. People can join up for those if they want to, although it won't take many from Indiana. They'll look more at the super hot spots to give these patients, but companies like Regeneron, Lilly, working on monoclonal antibiotics, both treatments, and those could evolve into vaccine therapies. Lilly very much involved in that. On the pure vaccine side, Pfizer, J&J, Oxford, Moderna, just a few of the companies. I wouldn't be surprised to see some vaccines start in Q1, but you have to remember, getting enough doses out, when you're talking about you need 7 billion doses worldwide, sometimes it's hard to, even if we could make 1 million doses a day, it takes 1,000 days just to make 1 billion. It'll be hard to ramp up production. So it'll take a while to get things out and get supplies. We're still dealing with a shortage of PPE here in the hospital, and that's been 6 months. We still have problems with N95 masks, with gowns, with face shields, PAPRs, a lot of supplies. It's just, and I don't see that shortening. We're still on allocation for many of these supplies, and there's more pressure for more of the supplies to be put out as more places open. So it's going to be a while that we're going to live with this. And I can't emphasize enough for people to practice infection control procedures. And I know that people my age do a much better job of doing that. I don't know that a lot of the young people understand the simple basics of virology, that if we don't get this transmission rate less than 1, it's going to continue to grow. And as we move then to conditions in the winter where we're inside more and congested more, it's going to be worse.
What are the best ways to stall that transmission or slow down the transmission that we can
say
do?
that again, Angela?
What are the things that we can do ourselves for our own personal selves to help slow that transmission?
Well, very basic. And what we hear on TV, it is an aerolized atmospheric transmission. So obviously wearing a mask. Is it 100% effective? No, but masks do decrease transmission. Hand washing, social distancing, most are common sense ideas that come forth in basic infection control procedures with washing the hands for 20 seconds. I, I don't know why this has become a political issue in some of these. I understand we have to weigh the economic consequences and we can't go back to a shutdown, but the pendulum can't swing both ways. We can have social distancing and have the majority of the economy open if we practice these procedures and get back to a full economic activity by getting that transmission rate less than 1.
Here's a question from the chat. What do you perceive hospitals' relationship with the Indianapolis hospitals going forward?
We'll continue to be involved in clinical partnerships with mostly Franciscan. We've had over a 30-year relationship with Franciscan in areas like cardiology, gastro, respiratory, multiple. They've been an excellent clinical partner with us. I think what we'll see change a little bit in the future is I talked about looking more at contracts that are population health based, which really means migrating to a risk-based environment. You'll see us look to the tertiary hospitals to partnership in providing those services with insurance companies and with government services. We are not looking at all towards an asset integration model. We're looking more at a clinical partnership model with tertiary facilities. We're financially sound on what we have, and to be honest, we don't see where an asset purchase by one of the tertiary hospitals of MHP is good for the community. We're just not looking towards that model.
What kind of screenings are we offering to detect health problems early, and how can people find out more about those?
Our website contains all of our screenings that we have, and those range wide across the board. Oncology is one of the most important screening areas. That's around the area of cancer, and we have prostate, breast are two of the most common. Obviously, colon cancer with colonoscopies in general surgery, but we offer lots of programs in the oncology screening area. We offer lots of programs in the cardiac area of monitoring and providing services, from carotid testing in the prevention of stroke, heart attacks. High blood pressure is the silent killer. There's no doubt that untreated high blood pressure, looking at a systolic over 130, diastolic over 90 long term, creates a lot of problems. All of our connections to any type of service can be viewed over the web, mymhp.org, or 392 docs number can also connect you with any of those areas that you're interested in. Don't think I can overly thank too much the support we get. The importance of a solid healthcare system in our area cannot be underestimated. I think times like this show that out. And we have the ability, and we'll be here, and we're going to continue to do that, and we're going to continue to do our part in working not only in the healthcare of the community, but also in the quality of life areas of the community. And a big part of that are the social determinants of care, in working to remove areas like food deserts on that, helping early learning, childhood, identify pediatric issues. We're going to continue to be involved heavily in those type areas that may not be traditional healthcare per se, but involved in what we term of the population of health. And those social determinants play a very, very important role in the quality of life for our individuals. And we can play a role in helping government and in helping private enterprise and in helping philanthropic organizations attain that goal here in Shelby County and constantly work to improve that. And you as an organization, along with those other people, providing not only financial resources, but human time resources are very appreciative.
Anybody want to ask any more questions? You're more than welcome to. Here comes Dan.
Yeah, Jack. I've been hearing from some of the clients that we've been working for. We just finished a job at Eli Lilly. They say they don't plan on going back to work until there's a vaccine available. Have you been hearing that about your larger businesses?
Very much so, Dan, especially the multinational and regional plus size businesses where they've been more, I want to say, capable of carrying out business because they were used to dealing, like Lilly with Germany and Puerto Rico and Asia. Yes, they are keeping people out. And we are seeing that across the board, consulting companies especially. Very few companies that we deal with are allowing employee travel. So it's had to go that way. And we're seeing also a lot of split type of where what you could call mandatory workers, where they have to be maybe on the front line, actually reporting in an area because it's necessary for production, but maybe administrative staff and other areas that involved HR, accounting, billing, maybe staying off. But you're right, Dan, we're seeing that.
Thanks.
What do you see the hospital's role in decreasing obesity, other than the classes, of course, that we offer, especially for obese people without disease?
Obesity is really a hard one. It's hard to change habits in someone my age. Not impossible, but hard to change the habits on that. You're going to see a lot of our focus be long-term, which means trying to reach the pediatric population of education and the younger generation in providing not only services that allow those type of nutritional practices, but along with exercise, et cetera. For people whose habits may already be ingrained, it really comes down to teaching, and as much as anything, teaching in diet, how to cook, what to cook with, and some exercises they can do either in the group, and you'll see us providing a lot of programs out in conjunction with the Y that are low stress, low impact type exercising. And I can't think of any better than a swimming pool. And the ability now to do that in the wintertime here, I think is going to make a big difference for a lot of people. Most people do understand the problems obesity brings in their life. So it's not necessarily an education of the problem with obesity. It's an education around how to defeat it. So we're playing an active role in that. Shelby County, unfortunately, ranks very poor within the state of Indiana, and Indiana ranks very poor nationally within that. We're also at trying to get the state involved more, the Hospital Association. Indiana's 48th in public health funding in the country. Only 2 states spend less per individual. We'd like to see the government play a little larger role in helping bring these programs forth. From a dietary standpoint, to stop the food deserts that we have and to provide some of the services like we're going to be providing in Shelby County.
Any more? Are you ready to do the door prize? We have these things came from the hospital gift shop, and you are all entered. Not you, Jack, but the rest of you are all entered. We have one cute little plaque. It says it's wood. You can see how it's made. It says everything is going to be all right. I think we would all like that right now. And look at this in this cute box. It's a little slate cheese board and a little knife thing. There, everything's backwards for me. There, and a little knife thing. Very, very cute. So, I have all your names in here. And the winner is Mary Jo Custer. Yay! I'll get this to you, Mary Jo. So, thanks everybody that came.
Woo!
Yeah, woo. I'm glad you came. And, tune in again next week if you want to. The more the merrier. It's kind of fun. And I just, I really do miss seeing people and having things like this together. And thanks so much for coming today.
Thank you. We enjoyed it.
Thank you, Dan.
Thank you, Dan. Thank you, everybody.
All right. Take care.
All right.
You too.
Bye.
Bye.